Laser spine surgery, robotic surgery, stem cell injections. These all sound super modern and really cool, but do they actually work? Here's what spine expert Dr. Georgiy Brusovanki has to say. As we're talking about these new innovations that are coming on the market, how do we know the difference, Dr. Brusovanki?
It's hard to know. It's hard, especially because the field is very narrow now, and there's a lot of information on very specific topics.
Right.
I love the second opinion. I think that if you're ever in doubt, it's always worth it to get a second opinion. You will feel better even going with a first opinion after you've talked to someone else and you've verified that that's the right way to go.
But I like the I like the patient connection as well. I think that's important.
I agree. Patients should be able to talk to other patients. I don't know how many practices allow that same thing that we do in my practice, where the patients have to talk to somebody who's already had an operation. But I think it's reasonable to ask for that.
Right.
Look online. There's great forums.
Yelp is a great tool.
I agree, but just beware of looking at publicly sort of voiced information, not educated information, information from other patients, from other doctors. You really have to be critical and detail-oriented. A T-leaf fusion is not the same thing as an A-leaf fusion. But on Facebook, someone may say, well, I had a fusion, and you won't necessarily know which one. One has a 3% failure rate, whereas the other one has a 36% failure rate.
Okay.
So as always, buyer beware.
So if you want to try a new treatment, what do? Should you get involved in clinical trials?
No.
No, why?
Well, look, because clinical trials imply that you're going to take the risk of an unproven procedure. Now, the only way that high risk can be tolerated is if there is no solution for your problem, or if the problem has a mortal risk, right? That's why trials are so common for cancer patients, especially with metastatic disease, because these patients are looking for something in a field where we have nothing good.
Right.
That's not the case with spine surgery anymore. So I don't think you should try experimental things. I think that, I'm a conservative doc, I'm a late adopter. I wait for studies to show me that if I commit a patient to a procedure, I'm not going to take them somewhere where they're going to get in trouble.
Right, you want to make sure that it works.
Right.
Okay, so let's talk about some examples of real improvements that we're seeing right now. And one example that you're very passionate about is the minimally invasive surgeries. So I want to talk about how this is done. Sure,
so it sounds like a gimmick, but the reality is that minimally invasive implies a frame change from what was done in the past. So because the human spine is in the middle of the body, to get to it was always associated with a lot of morbidity. And when you only had a single incision in the back to get to the front of the spine, which is in front of the spinal cord, you're talking about major morbidity, major risk. To a patient, it just looks like I have a little incision in my back. But what's deep inside is very important to sort of understand. So when you avoid cutting muscles, when your incisions are smaller, when there's no dead space, when you use tubes with great lighting, you have better visualization, yet there's less morbidity, there's no big open wound. Remember, classic surgery, you open up the patient wide enough that a light at the ceiling can provide you light inside the wound. So that means that it has to be a pretty big wound. Now, with the minimally invasive technique, we minimize that, and we keep going smaller and more precise. So now,
the best part about it is all the benefits you get from it, not just the small incisions.
Of course.
And the fact that you don't have to cut muscle.
Of course. I mean, there's a dramatic difference, and studies really do go along with this. Multiple studies talk about how minimally invasive surgery patients go back to work sooner, they have less pain, they get back to their normal activities sooner, there are less infections because of small incisions, there's no dead space, they don't need blood transfusions as much. So it's a change in an entire perception on how to operate. And by the way, there's minimally invasive options in other surgical fields, general surgery, obstetrics, etc.
I know that something else you discussed on previous shows is something called disc replacement, and our caller actually asked a question about that as well. So what is disc replacement? Is this new, or is it just something that's been improved upon?
So look, 15 years ago, when I started doing research on disc replacement in animals and cadavers, it was a gimmick. It was not accepted, and very few doctors did them. So the American Academy of Orthopedic Surgeons, which is kind of like our governing body, has become very clear over the past few years that this is now the standard of care. For the cervical spine, you minimize the chance of adjacent level disease. For young people, it would be a bad idea to do a fusion. When there's minimal arthritis and it's just a disc problem, do a disc replacement. So now we've gone from a gimmick to something that has undergone 20 years of research with thousands and thousands of patients. So it is not a gimmick. I believe that this is now the new standard.
And you do this a lot in your practice?
I do, because I always try to avoid a fusion unless a patient has deformity or instability.
Now, another big innovation in the medical industry is robotic surgery.
Sure.
So talk to us a little about robotic surgery and what it is.
So again, sounds like a gimmick, right? A robot, right?
Robot is fixing my spine.
I want to run to it. Yeah, of course, I want a robot. But the reality is that this is no longer a gimmick. Again, 15, 20 years ago, this was sort of crude. Now, here you're seeing.
So just to be clear, the robot is not doing the surgery. The surgeon.
Right, absolutely.
Is okay.
The robot is just a tool. The surgeon controls it with the help of his assistants, and what it allows you to do is to be much more precise with less morbidity. You know, I don't need to put my hand into a wound anymore. I have specialized tools. The robot is the next level of specialized tools. So, for example, to put a screw into the spine has about a 5% error rate. Now, when you use X-rays and a minimally invasive technique, it goes down to about maybe 2 to 3%. With a robot, it goes down to less than 1%.
Wow.
Now, that sounds like splitting hairs, but when you're talking about thousands and thousands of surgical patients, 1% is a huge number of complications. So a robot is the way to go if you're doing anything more than a 2-level fusion, because not only is it more precise, it will also make the operation faster, less blood loss, and it has really made a big difference. There's
So that's what we have the standard of care now, but are they improving upon robotic surgery, or will we see more?
Absolutely, absolutely. So in my world, spine surgery, robotic surgery is really just still sort of an aiming arm. It's an assist,
right,
with like gallbladders, appendectomies, hernias. The robot is now probably 50% of the action, and in the future you will see the robot doing the entire procedure. My old professors at Duke were working on ways to do brain surgery.
Using robotic surgery.
Exactly, because remember, you can't just take things away, getting to the middle of the brain. Tumors commonly are inoperable because of how much mobility the patient would take in the approach. Now, a robot can sneak around corners, tight spaces where no human can do in a safe way, and then perform the same operation. So this is going to happen within 5-10 years of our life.
That's fascinating. How mind-blowing is that? Just think of what healthcare and surgery will look like in just a few short years. Wow.